Very good morning to all of you. A warm welcome to the specialty update on gastroenterology conducted by the Ceylon College of Physicians. This is the month of April, and then this is the month of gastroenterology. As you know, we have divided each month of the year into a specialty, and this month, the Young Physicians Forum as well as the specialty update is on gastroenterology. And then, of course, I apologize for any inconvenience caused by switching from a hybrid to a pure Zoom meeting. The reason for that was due to many crises people are facing. We felt it was better this way. And then, of course, I think all of us have an obligation to save as much fuel as possible because Indian fleet line is likely to run out very soon. So it's considering everything what we felt was best for everybody, best for the country as well. And then this is the first specialty update or CCP thing I'm conducting while seated outside near under an ahala tree in the Faculty of Medicine in Galle. This is where I work. So warm welcome to you from Galle. And then we are doing this in collaboration with the Sri Lanka Society of Gastroenterology. And it is my great pleasure to invite, to welcome all 5 speakers, as well as the president of the Sri Lanka Society of Gastroenterology, Professor Rohan Siriwardana, and then, of course, Professor Madhunil Niriyalla, who helped us put this wonderful program together. I'm very grateful to the 2 of you, as well as the speakers. So, and a warm welcome to all the registered participants as well. And then thank you, Nalina, for very quickly attending at short notice to all the IT facilities, facilitation of this program. And then without any further ado, may I invite my friend and colleague, Professor Rohan Siriwardana, to speak a few words to you and then introduce the speaker lineup and the program lineup. Have a very pleasant and a fruitful program. That's my wish. Thank you.
Thank you, Arosha. First of all, on behalf of the Sri Lanka Society of Gastroenterology, I would like to welcome you all for this specialty update. I would like to thank the Ceylon College of Physicians for organizing this event. And I think we may belong to different specialties, but at the end of the day, what really matters is the patient outcome. And the best way to achieve that is updating our knowledge. And this is what we are trying to do today. First of all, I would like to thank Professor Niriyalla, who organized, line up the topics and organized speakers for today's discussion. And today we have 5 speakers representing our college, our society, on this specialty update on gastroenterology. Dr. Kulisha Kodisinghe, who's a consultant gastroenterologist from General Hospital Mathura, who will be discussing with us about the evidence-based approach to irritable bowel syndrome, one of the most one of the commonest conditions that we encounter in our practice. And Dr. Eranga Thalagala, consultant gastroenterologist from General Hospital Mathale, will be discussing with us about the medical management of inflammatory bowel disease in 2022. And Dr. Manangal Sernayaka from Teaching Hospital Kalutara will be discussing with us about the evaluation and management of clinically significant portal hypertension. And Dr. Hasta Vijayavanta, consultant gastroenterologist from Teaching Hospital Ratnapura, will be discussing with us about optimizing management for maximum benefit in MAFLD. And finally, Dr. Achini Vitanachi, consultant gastroenterologist from General Hospital Hambantota, will be discussing the management of hepatocellular carcinoma in 2022. Let me once again thank the organizers and invite you all for a fruitful discussion. Thank you very much.
So to kick off today's proceedings, I'm going to speak about an evidence-based algorithmic approach to the problem of irritable bowel syndrome. So as you know, this is a very common problem we face as clinicians. So this is an overview from my presentation. We are going to discuss about the diagnosis a little bit, and my main concern today is going to be on the evidence-based management part of the irritable bowel syndrome. As clinicians, we face a lot of patients who come with altered bowel habits. But the problem is, do we investigate each and every patient, which is not practical. Because of this, this foundation, international foundation called the Rome Foundation, has put forward the classification for functional gastroenteritis, irritable bowel syndrome being one of them. So currently, this classification is in the 4th iteration. So according to this, there are certain diagnostic criteria, and there are 3 main criteria for irritable bowel syndrome. The patient should have recurrent abdominal pain with 2 or more of the following features. That is, the pain should be related to defecation. It can either improve or worsen after the defecation. And there should be a change in the stool frequency, less than 3 times a week, which is constipation, or more than 3 times a day. And there should be a change in the stool form. Now, this is a very subjective thing, because constipation or diarrhea for one person might not be a constipation or diarrhea for another. So for the purpose of this classification, they have used the Bristol stool chart, which gives a pictorial representation of different types of stools. As you can see, the type 1 and type 2 is called constipation. 6 and 7 are called diarrhea. So the patient should have recurrent abdominal pain plus 2 or more of the other 3 features. So abdominal pain is a must. A patient who has altered bowel habits without any abdominal pain, you can't diagnose it as irritable bowel syndrome. Then the patient should have chronic disease. By chronic, it means that the symptoms should have been there for, the symptom onset should have been about more than 6 months before. And the symptom duration should have been for more than 3 months in that period of 6 months. And the frequency of the symptom should be at least once a week. And the third criteria is absence of obvious anatomic or physiological abnormalities identified by routine diagnostic examinations. They have introduced this caveat because to make sure that people don't miss other sinister pathologies. So when it comes to diagnosis, routine history and routine examination is a must. Examination includes abdominal examination and anorectal examination as well. Out of the routine investigations, full blood count should be done in all patients. Inflammatory markers, CRP and fecal calprotectin in patients who are non-constipated, either diarrhea or mixed irritable bowel syndrome. Stool full report and culture, again in non-constipated IBS. Serological tests for celiac disease are recommended in the guidelines, but this is actually not very relevant to our country. If you suspect hypo or hyperthyroidism, you are supposed to do thyroid tests. What about the place for colonoscopy? Should all patients with altered bowel habits undergo a colonoscopy? Definitely not. Patients more than 50 years of age should have a colonoscopy. Those who are younger than this should have a colonoscopy if there are alarm symptoms or signs. That is, the patient may have atypical symptoms like rectal bleeding, weight loss, nocturnal symptoms like nocturnal diarrhea is a suspicious sign, fever, and any very recent change in the symptoms. And if the patient has a family history of colorectal carcinoma, IBD or celiac disease, again, the patient should have a colonoscopy. And abnormal physical examinations that you find during the examination, abnormal routine investigations out of the ones that you have done, and in patients who have failed empirical therapy for irritable bowel syndrome, again, there's a place for a colonoscopy. And in patients who have non-constipated IBS, you are supposed to take biopsies from the right and left colon when you do a colonoscopy. This is to exclude the possibility of microscopic colitis. So moving on to the my main part of my presentation, which is treatment for irritable bowel syndrome. Actually, not all patients with the IBS need treatment, because the patients who don't have much symptoms, they might just be satisfied with your reassurance that there's nothing sinister going on. Treatment actually depends on the degree of symptoms the patient have and how the symptoms affect their day-to-day lifestyle. So there are 3 main categories when it comes to treatment. diet and lifestyle modification, pharmacotherapy, and psychotherapy. We'll be discussing the evidence base for each and every one of these different modes of treatment. The ones I have indicated in red are the ones that are available to us in our country. So as you can see, there's a lot that are not available to us. So diet and lifestyle modification, the simplest things that you can try is alteration of fiber intake. Now, when it comes to fiber, there are two main types, insoluble and soluble. Insoluble fiber is not good for IBS because it can worsen the bloating and abdominal discomfort. These are present in hard to chew parts of grains like whole grain and vegetables like cabbage and fruit like the skins of fruit. Soluble fiber, on the other hand, is beneficial, which is present in starchy foods. And a common pharmacological preparation that we can use is psyllium, which comes under the brand name of Fibogel, which has soluble fiber. Lactose restriction might be beneficial because compared to the normal population, IBS patients have been found to have lactose maldigestion more commonly. And in Asians anyway, it's common. Fat restriction might be tried, and generally encouraging healthy eating habits, reducing alcohol and caffeine, and encouraging exercises are beneficial. So these are general things that we can try, but are there any more specific, more advanced methods of dietary modification? Yes, there is. Low FODMAP diet. The FODMAP mnemonic stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So these are actually non-absorbable saccharides, which when they are present in the gut, they cause an osmotic effect and draw the water into the gut and can worsen the bloating and abdominal discomfort. In addition, they are broken down by the bacteria and they produce hydrogen. So this is the landmark trial that has investigated the benefit of low FODMAP diet. This trial has been done by a team in Monash University in Australia. So as you can see, the low FODMAP diet, which is indicated in the lower line, this one has benefit with regard to mean overall gastrointestinal symptoms compared to the typical Australian diet, which is indicated by the top line. When it comes to this is for IBSM patients. When it comes to healthy controls, there's no difference between the two types of diets. Same benefit is seen in with regard to bloating, abdominal pain, and passage of wind. But how is this applicable to our diet? So this table summarizes the types of food that has FODMAP and non-FODMAP. So the FODMAP foods, wheat is high in FODMAP, but rice doesn't have FODMAP. Certain vegetables has FODMAP, but certain ones don't have. When it comes to fruits, fruits that are very sweet have high FODMAP, and non-FODMAP fruits, mainly banana and pawpaw, they don't have much FODMAP. Milk, cow's milk are high in FODMAP. Other types of milk like soya milk doesn't have FODMAP. When it comes to sweetness, very sweet fruit juice, honey, large doses of fructose are high in FODMAPs, but limited amounts of sugar can be allowed. So the American College of Gastroenterology Guidelines 2021, which is the latest guidelines on IBS, recommend a limited trial of low FODMAP diet in patients with IBS because they improve global symptoms. But they recommend this be done by under the guidance of a properly trained GI dietitian. This is a problem in our country because we don't have this specialty. When it comes to fiber supplementation, this meta-analysis shows the studies that have been performed. The first part, which is bran, which is a insoluble fiber. As you can see, there's no statistically significant benefit with bran. But when it comes to isfagula, which is same as psyllium, which is found in Fibogel, there's a statistically significant difference. Benefit actually with a number needed to treat of 7. Because of this, we can recommend use of soluble fiber in these patients. The ACG recommends that soluble but not insoluble fiber be used to treat global IBS symptoms. What are the place of loperamide? The guidelines, the latest guidelines actually, they don't recommend loperamide as first-line therapy because it improves diarrhea, but it doesn't improve the other global symptoms like abdominal pain and discomfort. It doesn't improve those, but improves only diarrhea. But this is because they have better drugs. They have this mixed opioid agonist and antagonist. Loperamide is a opioid agonist, but they have a mixed agonist and antagonist called eluxadoline, which actually improves the diarrhea and improves the global symptoms as well. But we don't have this in our country, so we use loperamide to treat the diarrhea component, but you have to remember that it won't give benefit with regard to abdominal pain or discomfort. 5-HT3 receptor antagonists. This is a class of drugs which ondansetron belongs to. So the evidence with regard to this, this is with regard to global IBS symptoms. As you can see, overall there's a benefit with regard to global IBS symptoms, but there's no evidence with regard to ondansetron. These other drugs are beneficial, but we don't have them in our country. When it comes to abdominal pain and discomfort, there's evidence with regard to ondansetron and it doesn't give any benefit, but the other drugs do with regard to abdominal pain and discomfort. When it comes to diarrhea, that is abnormal bowel habit, ondansetron has a benefit, as do other drugs. So the guidelines they recommend, what they recommend is actually alosetron, which is same class of drugs, but we don't have this in our country because it improves the diarrhea and improves the global IBS symptoms. Ondansetron improves the bowel symptoms, but not the abdominal pain and discomfort, again similar to loperamide. So if you want to improve the bowel symptoms only, you can try ondansetron in these patients. Probiotics are very popular drug among clinicians for irritable bowel syndrome, but is there any trial evidence for this? When it comes to global symptoms or abdominal pain, it improves. There's a statistically significant improvement with regard to probiotics. Bloating scores again improves, and flatulence scores again there's an improvement. So this is mean that we should use probiotics because everything seems to improve when you use probiotics. But guidelines, they actually suggest against the use of probiotics for the treatment of global IBS symptoms. This is because there's only limited trial data and mainly because of the heterogeneity of the different combinations available. So even when you go through this one, you can see there's a combination. Combination has different kinds of different organisms, and then there are versions which have lactobacillus only, which have bifidobacterium only, which have Saccharomyces only. So because of the various kinds of different preparations and lack of data with regard to one preparation, they suggest against the use of probiotics in irritable bowel syndrome. Rifaximin, this is an unabsorbable antibiotic. This data is for non-constipated IBS, not for constipation. And as you can see, rifaximin improves the global symptoms with a number needed to treat of 9. What is important is that it improves the symptoms in patients without previous rifaximin therapy, but in patients who have been previously exposed to rifaximin as well. So this means that you can reuse rifaximin. You can give rifaximin, and if the patient responds to that, but later on they get the symptom again after a few months, you can give a short course of rifaximin again. Generally, we give it for about 10 to 14 days at a dose of about 400 TDS to 550 BD. So the guidelines also recommend the use of rifaximin to treat global IBS symptoms. We have this in our country. But this is, you have to remember that this is only for diarrhea predominant version of irritable bowel syndrome. What about laxatives? Guidelines actually recommend against the use of laxatives, mainly the polyethylene glycol version, which is the one that is available in Clean Prep and things like Movicol, to relieve global IBS symptoms in patients with constipation predominant IBS. They suggest against the use of this. Why is that? Because they have better drugs, secretagogues, which are lubiprostone and linaclotide. They recommend to treat global IBS symptoms with these drugs because they improve the global symptoms and relieve the constipation. But since we don't have this, there's a place for other laxatives just to improve the bowel component of the disease. 5-HT4 receptor agonist, tegaserot, we don't have this, but they recommend for IBS constipation predominant variant. Antispasmodic agents, we commonly use these for the pain component in these patients, things like buscopan or mebaverine. But what are the evidence? For the pain relief, there has been no statistically significant benefit with regard to mebaverine and hyoscine, which is buscopan. When it comes to abdominal distension and bloating, again, mebaverine doesn't have a statistically significant difference. When it comes to global symptoms, mebaverine, no statistically significant difference. There has been some benefit with hyoscine, but mebaverine doesn't have a statistically significant benefit. Peppermint oil, which is again a antispasmodic, improves abdominal pain, improves global symptoms as well. So the guidelines recommend against the use of antispasmodics to treat global IBS symptoms, but the antispasmodics that they have, they don't have mebaverine, they have hyoscine. So they recommend against the use of hyoscine, but they don't make a recommendation for mebaverine. But as you can see in the trial evidence, there doesn't seem to be much benefit for mebaverine as well. But they recommend peppermint oil, which offers overall benefit with regard to pain and global symptoms as well. Antidepressants, what's the place of antidepressants? Two main classes, tricyclics and SSRIs. Both improve global symptoms. When it comes to abdominal pain, tricyclics improve the abdominal pain, but SSRIs, there has not been any, there's a trend towards benefit, but there has not been a statistically significant difference. The number needed to treat is for tricyclics 4.5, SSRIs 5. So the guidelines recommend that tricyclics can be used to relieve global symptoms of IBS. They don't mention about SSRIs here. But the problem is for patients who have constipation predominant IBS, if you give a tricyclic, you can worsen the constipation. So in these patients, we can try a SSRI, which actually has a side effect, causes a little bit of diarrhea as well. Psychological therapies. So this meta-analysis gives the evidence with regard to different kinds of psychological therapies. The ones I have indicated in red are the ones that have some benefit. Cognitive behavioral therapy, relaxation therapy, multi-component psychological therapy, hypnotherapy, and dynamic psychotherapy. All these give statistically significant benefits with a number needed to treat of 4. So the ACG guidelines recommend gut-directed psychotherapies for global IBS symptoms. This is because these are harmless, and they have shown that even after you stop these psychotherapies, the benefit persists even after you stop the sessions. So this table summarizes all the drugs and other measures that have been that can be used to treat IBS patients, and the predominant symptoms that they can be used in. So in a patient with global IBS symptoms, there's a place for dietary manipulation, fiber supplementation, rifaximin, peppermint oil, tricyclics, and psychotherapy. They give benefit with regard to the whole global symptoms of these patients. There are other drugs that are not available to us. When it comes to diarrhea, dietary manipulation gives some benefit. Loperamide improves the diarrhea, but as I said earlier, it doesn't improve the global symptoms. Ondansetron again improves the diarrhea, but not the global symptoms. Rifaximin improves the diarrhea. Place for probiotics is questionable. When it comes to constipation, what we have is laxatives. It improves the constipation, but not the global symptoms. We don't have these other better versions. When it comes to pain, antispasmodics, there's a questionable pace. Peppermint oil recommended in the guidelines. And this is available in some formulations in our country as well. And the pain, main thing that we have in our situation is antidepressants. When it comes to bloating, dietary manipulation gives benefit. Antidepressants have benefit. Probiotics has a questionable place. So in summary, the ROM criteria helps to diagnose IBS. Abdominal pain is an essential feature without which you can't diagnose IBS. Few routine investigations are recommended. Full blood count, inflammatory markers like CRP and fecal fat protein, stool fluid report and culture, and thyroid test if the patient has clinical features of hypo or hyperthyroidism. Colonoscopy recommended if the patient is more than 50 years old or in the presence of alarm symptoms and signs. Treatment consists of dietary treatment, pharmacological treatment, and psychotherapy. Thank you. If there are any questions, I'm happy to answer.
Thank you very much, Dr. Padisinghe, for this excellent overview of irritable bowel syndrome. And the forum is now open for questions. We haven't received any questions up to now. If you have any questions, we have time for 1 or 2 questions. So I would like to ask one question from Dr. Padisinghe. You were mentioning about several medications, different categories. Are there any combinations that we can use and practice in Sri Lanka? And also whether we have any evidence with regard to psychotherapy in the Sri Lankan population?
With regard to your last question, I don't think we have any local evidence with regard to psychotherapy with our patients. Combinations, usually these drugs come in individually, but combination that I can think of is there's a combination of mevaverine plus soluble fiber. Psyllium plus mevaverine, there's a combination called Colospas fibro, but otherwise usually these drugs come in individually. If you want to give several drugs, you have to give them individually.
Okay, we have one question. One of our attendees asking causes for irritable bowel syndrome.
Yeah, actually, causes. It's a problem between the gut-brain axis. The gut and the brain communicates via neurons. So there's the brain tends to interpret the signals that the gut gives it to a high extent, high sensitivity, and the signals that the brain sends back to the gut, again the gut tends to overinterpret it. That's why you get the the bowel symptoms out of that. The pain because the bowel sends more signals to the brain, and the gut symptoms because the bowel tends to interpret the brain symptoms more than a normal person. But there are no specific like genetic basis or anything behind that.
Okay, thank you very much. In the absence of further questions, I would like to thank again Dr. Padisinghe for joining us today, and we would like to hand over the certificate of appreciation for giving us this talk. Thank you.
Thank you.
So we are moving to the next talk. Dr. Iranga Thalagala, consultant gastroenterologist and hepatologist from Martale, is going to talk to us on right patient, right therapy, medical management of inflammatory bowel disease in 2022. Over to you, Iranga.
Good morning. Thank you very much. So today I'm going to talk about right patient, right therapy, the medical management of inflammatory bowel disease in 2022. This is a very broad topic. I will try my best to finish this in 20 minutes. So what is IBD? It is a chronic, progressive, relapsing and remitting disease of the GI tract. It mainly consists of two diseases, ulcerative colitis and Crohn's disease. So ulcerative colitis, usually the inflammation begins in the rectum and it moves upward continuously. And usually the inflammation is confined to the mucosa. Whereas in Crohn's disease, it can affect any part of the digestive tract from mouth to anus. And there is transmural inflammation leading to fistula formation, stricture formation, and the inflammation is not continuous. There are skip lesions. So not only GI tract, there may be some extraintestinal manifestations as well. So there may be eye involvement, skin involvement, and the musculoskeletal system involvement and hepatobiliary involvement. And also some IBD patients are prone to develop thromboembolism. So if we let this inflammation to proceed without controlling, it can be associated with dreaded complications such as abdominal abscesses, fistula, and strictures. And also this uncontrolled inflammation can increase the risk of GI malignancies, and it can also significantly impact on patient quality of life, activities of daily living, and obviously it's going to increase the healthcare costs. And therefore, it is very important to identify these patients and manage their inflammation properly. So, a few words about pathogenesis. The exact cause of IBD remains unknown, and it is a complex interplay between multiple factors. Obviously, there is some genetic predisposition, and there's dysregulated immune response going on, and there are some mucosal barrier dysfunction. That is, their epithelium is more leaky than the normal healthy individuals, and there is a disturbance in microbiota, and there are some environmental and lifestyle factors such as diet and also smoking. So at the moment, most of our treatment focused on this dysregulated immune responses, and therefore most of our drugs are either immunosuppressants or immunomodulators. So what are the available management options for IBD? There are medical management options and surgical management options. Under medical management options, there are nutritional interventions, conventional medicines such as corticosteroid and immunomodulators, the biologics, biosimilars, and new small molecules, and fecal microbiota transplant. Under surgical management, we might need surgical interventions when there's failed medical treatment, when there are any complications, as well as we can use surgical intervention as a first-line treatment. For an example, if someone is having limited ileal Crohn's disease, this right hemicolectomy even could be curative. So this diagram shows key events in IBD drug development. The first effective drug was identified in 1955. It was cortisone. And in 2002, there was a major breakthrough. The TNF-alpha therapy, that is infliximab, was found to be effective for IBD. And in 2013, vidofludimus was introduced. In 2016, ustekinumab was introduced. And in 2018, the small molecule JAK inhibitors was introduced. And we can appreciate that during the last decade, there was a major expansion of the available medical options. So this was the traditional treatment approach for IBD, and sometimes we call this as a step-up approach. So in the past, when we encounter a patient with active IBD, first we started with less potent drugs, and if those drugs failed, we moved up to more potent drugs. So this may be still valid for a mild disease, but now we are generally moving away from this traditional strategy, because sometimes we encounter patients with moderate to severe disease. Of course, in them, these less potent drugs are not going to work, and we are just wasting our time, and we are risking patients' lives. So the time is important because there's a therapeutic window of opportunity. If we can diagnose and if we can initiate disease-modifying drug, we might be able to change the disease natural history or the progression. So individualized approach is needed. Right patient, right medication. So after the diagnosis, we should do a risk stratification, and according to that, we should select the right medication. So what are the current strategies aim for? So we have three main aims. So we should try to achieve deep and long-lasting remission, and we should aim to prevent complication, and we should aim to hinder the disease progression. In order to achieve this, in high-risk patients, we might have to introduce biologics and the combination therapy early in the disease course, and we need tight control and frequent monitoring of the inflammation. And if the patient is not responding, we have to adjust the therapy, which is called as treat to target strategy. So these are our goals. So our first goal is the symptom control, and our second goal is deep remission, and the third one would be the disease modification, which is coupled with tight monitoring. So these are our treatment targets. We have immediate target, intermediate targets, and long-term targets. So the clinical response defined as at least 50% reduction of symptoms is an immediate target. And of course, we can appreciate that going into the toilet 10 to 20 times per day is not so fun. So our immediate target is to achieve a clinical response, and clinical remission and biochemical response are our intermediate targets. The endoscopic healing is our long-term target, and in children, we should try to achieve restoration of normal growth. So these last two, the mucosal or the histological healing in ulcerative colitis and transmural healing in Crohn's disease would be our ultimate targets, but at the moment, we don't consider those two as our formal therapeutic targets. So this is the same thing in a more graphical way. So it is obvious that one size does not fit all. So there are many factors to consider. So the first thing would be the underlying diagnosis, whether the patient is having Crohn's disease or ulcerative colitis. For an example, nowadays we don't use aminosalicylating Crohn's disease. So there's no point of prescribing aminosalicylate in Crohn's disease patient. And the second one would be the disease phenotype. Although we label a patient as a Crohn's disease, actually the Crohn's disease is a collection of several phenotypes. Some patients only have inflammatory disease. Some patients will have inflammatory plus penetrating disease. So the treatment depends according to the phenotype. For an example, if someone is having inflammatory Crohn's disease, we might be able to treat that patient just with corticosteroid and immunomodulators. But whereas in penetrating Crohn's disease and perianal Crohn's disease, we might need biologics and immunomodulators right from the beginning. So then the other factor we should consider is the disease severity, whether the patient is having mild disease or moderate to severe disease. And also we should assess the risk factors for poor prognosis. If those are present, we should go for more intense therapy from the beginning. And also presence or absence of extraintestinal manifestations are also important. The other thing we have to consider is age. For an example, in the pediatric population group, we try our best to minimize the corticosteroid use in that group. And there are also special patient populations such as pregnancy and elderly. In the pregnancy, we don't use methotrexate and we don't use tofacitinib. And in elderly, we don't use thiopurine because of the increased risk of malignancy. So also we have to assess the past medical history, especially the tuberculosis, hepatitis B, C, and varicella infection. And also we have to assess the medical compliances, because although rare, most of these drugs are associated with very serious complications. Therefore, the compliance of the patient is very important. And also we have to consider the socioeconomic status. This is not that much applicable to our country because of the free health, but in our country, we have to assess the availability of medication. There's no point of starting a million worth biologic if we can't continue it. And also we have to consider patients' concerns as well, such as needle phobia. So I was talking about poor prognostic factors. These are the poor prognostic factors for Crohn's disease. So younger age, smoking, longer disease duration, early use of corticosteroid, and the disease location, especially the upper GI Crohn's disease, is associated with poor prognosis. And also there are some other factors you can see. So, and these are the poor prognostic factors in ulcerative colitis. The younger age at the diagnosis, extensive colitis, severe endoscopic disease, previous hospitalization for colitis, elevated CRP, and low serum albumin. If these poor prognostic factors are present, we should go for a more intense treatment, which is also known as top-down treatment. So if someone is having a low risk ulcerative colitis, the initial therapy would be amino salicylate and or steroid. For Crohn's disease, it would be steroids or immunomodulators or a combination. So we should remember that steroids should not be used for longer periods of time. We have to taper steroids over 60 days to prevent withdrawals or relapse. The low risk patients who do not respond or lose response to initial therapy should be escalated to therapies recommended for patients with moderate and high risk. So for the patients with moderate and high risk, for ulcerative colitis and Crohn's disease, for both conditions, we can use either immunomodulator therapy or biologic or combination therapy. That is biologic plus immunomodulator. So, but in the initial stage, we might have to bridge with corticosteroid therapy because it might take some time to these drugs to act. So until that, we might have to bridge the treatment with corticosteroids. And then we should assess for remission. So what does remission look like? So there are clinical targets and biomarker targets and endoscopic targets. I'm not going into a detail of this slide. So what should we do if the patient is not in remission? Then we should optimize current therapy. To optimize current therapy, the therapeutic drug monitoring is needed, but unfortunately in our country, we don't have this facility. So after optimizing current therapy, we should reassess the response. If still there is no response, we might have to switch to a different therapy. And again, we have to reassess the response and adjust our treatment according to that. So we have to remember that there's no correct order of treatment. So now more details into the pharmacological interventions. Unfortunately, I might have to skip some slides due to the time constraints. So something about this budesonide. So this is a second generation cephalosporin, second generation corticosteroid, which has a very extensive first pass metabolism. Therefore, it has less adverse effect and better tolerability, and it is not associated with adrenal suppression or significant reduced bone mineral density. So both oral and rectal forms are available. So I will skip these next few slides. So biologics. So the biologics has revolutionized the management of IBD during the last 2 decades. As I mentioned, we have started using infliximab since 2020 and the other biologics since after 2012. So there are 2 main groups of biologics we use in IBD. First one is pro-inflammatory cytokine inhibitors, under which we have TNF-alpha inhibitors and interleukin 12 and 23 inhibitors. And the second class of biologics used in IBD is integrin inhibitors. Few words about anti-TNF therapy. So the overexpression of TNF-alpha can cause chronic inflammation and tissue damage. The most commonly used anti-TNF therapy is infliximab and adalimumab, which is available in our country as well. And we might need to use a combination therapy, that is anti-TNF plus immunomodulator, that could be azathioprine or 6-mercaptopurine or methotrexate, because it has been shown that this combination therapy yields best outcomes because it is associated with highest response rates and lowest rates of neutralizing antibodies and lowest rates of loss of response. Infliximab, this is a chimeric antibody. It means this is derived from both human and mouse and DNA. So this has a relatively high immunogenicity. Therefore, if we use infliximab, it is best we can combine it with the immunomodulator. So this infliximab is approved for both Crohn's disease and ulcerative colitis. We can use it in steroid-dependent or resistant disease, and as a second-line treatment when the conventional medicine fails, or as first-line treatment in moderate to severe disease, and also as a rescue therapy in acute severe ulcerative colitis. We have to use loading doses and maintenance doses. So the loading doses we give at week 0 to 6, and from 14 week we give maintenance doses 8 weekly. So if there's loss of response, we might have to either increase the dose or to reduce the dosing interval. This is infliximab that has a very quick onset of action. So efficacy is usually seen in 2 weeks, and the median time for fistula closure is 3 months. But we should remember the primary there may be primary non-responders, which could be higher up as 40%, and there may be secondary loss of response after 1 year. Again, it can range from 23 to 46%. Adalimumab is the second anti-TNF, which is commonly used for Crohn's disease and ulcerative colitis. This is given as subcutaneous injections. Again, the loading dose from week 0 and week 2. Then from week 4, again, we have to give subcutaneous injection fortnightly. And if there's a loss of response, first we can increase to weekly dosing. As I mentioned earlier, the therapeutic drug monitoring should be done during anti-TNF therapy. And this chart shows how to guide our treatment according to the drug concentration and the presence or absence of anti-drug antibodies. So the anti-integrin therapy, and we know that integrin is a cell surface glycoprotein receptor which mediates the homing of leukocytes into the surrounding tissues. So by using anti-integrin, we can prevent lymphocyte migration to the intestinal tissue. The most commonly and the currently licensed anti-integrin therapy is vidofludimus, which can be used in both ulcerative colitis and Crohn's disease for both moderate to severe disease, both in previously biologic exposed patients and also biologic naive patients. So this is effective for inducing, for both inducing and maintaining the remission. And we should remember that this has a because this could take some time to act. So the full response might take 2 to 3 months. So until such, we might have to bridge the treatment. And one good thing about vidofludimus is it is gut specific. So the risk of opportunistic infections are less with vidofludimus, and also the cancer risk is less. The other category is anti-interleukin 12 and 23 therapy. And interleukin 12 and interleukin 23 plays an important role in the cytokine storm which can be found in the IBD. So the most commonly used anti-IL-12 treatment is ustekinumab. It is a fully humanized IgG1 monoclonal antibody. Therefore, the immunogenicity is relatively less, and we can use this for moderate to severe Crohn's disease and ulcerative colitis. This is beneficial in patients who are having psoriasis and IBD, and interestingly, some patients develop psoriasiform rash when we treat them with anti-TNF. So in these kind of patients, the ustekinumab is beneficial. So this is the most latest innovation. So the new small molecules, JAK inhibitors. The JAK inhibitors can block multiple signaling pathways, and the main benefit of this is we can administer this orally. So it is more convenient for the patient, and there's no need of hospital admissions. So tofacitinib is licensed for ulcerative colitis, and we usually start the treatment with 10 milligram twice daily for at least 8 weeks. After 8 weeks, we should assess the response. If the patient has responded, we might have to we might consider to reduce the dose to 5 milligram twice daily. If not, we will continue the 10 milligram twice daily dose until the week 16. If there's no adequate therapeutic response, we'll have to stop the treatment. So two main adverse effects of tofacitinib is herpes zoster and thrombosis. So especially the pulmonary thrombosis. So there are very interesting emerging treatments. The first one is apheresis therapy, in which we try to isolate and absorb one or more specific leukocytes in the peripheral blood, but these are still in the research stages. And also we can try stem cell transplantations. The most commonly used stem cell transplantation method is hematopoietic stem cell transplantation. And also since 2019, the research being conducted combination with combining two different biologics with different modes. For an example, there are research being conducted with adalimumab and vedolizumab for ulcerative colitis. And also there are various studies being conducted with fecal microbiota transplant in ulcerative colitis, mild to moderate ulcerative colitis, but now there are some black box warning against that fecal microbiota. So therefore, it is these methods are still not in guidelines. So these are my take-home messages. IBD is a complex and heterogeneous group of diseases, and we have to decide on the treatment according to the disease severity and risk. And we have to start effective treatments early, and we have to treat to target, and we have to do tight monitoring for response and for potential complications. And according to the response, we have to optimize the treatment. And please note that my presentation was based on the BSG guidelines and the American College of Gastroenterology guidelines. And thank you very much. I would like to thank the CCP and the Sri Lankan Society of Gastroenterology for giving me this opportunity. And if there are any questions, I would like to take those now.
Thank you very much, Dr. Thalagala. We haven't received any questions yet. And
that's all right. Okay.
In the interest of time, we will move on to the next talk. Before that,
Okay,
on behalf of Ceylon College of Physicians, I would like to hand over the certificate of appreciation for giving us a talk on update on management of inflammatory bowel disease. Thank you.
Very much.
So next talk is going to be conducted by Dr. S.M. Senanayake, a consultant gastroenterologist from Teaching Hospital, Kalutara. And Dr. Senanayake is going to talk to us on evaluation and management of clinically significant portal hypertension. Over to you, Dr. Senanayake.
Right. So the topic given to me actually is the evaluation and management of clinically significant portal hypertension. It's really, there is a new guideline called the Baveno 7. This topic actually decided by Professor Niriella really to cover this new guideline. First of all, what is Baveno? Baveno is apparently a very beautiful scenic town in Italy. And why is it relevant to us? That is, it happens to be the place that always that the guideline committee go to decide and discuss portal hypertension. So this is actually the consensus statement that my whole talk is based on, Baveno 7, which is renewing its consensus in portal hypertension. And the whole ethos of it is to give a personalized care to portal hypertension. So why they always keep going to Baveno, we don't know. It must be for some academic complicated reason. So the overview of this guideline talk is about talking about a hepatic venous pressure gradient, which we use to measure portal hypertension, and the different non-invasive tests that we can use, and how to prevent the first episode of decompensation in a cirrhotic patient, and the impact of etiological and non-etiological therapies on the course of cirrhosis, and how to manage an acute bleed. Is there anything new that Baveno tells us, and how to prevent something called further decompensation. So to quickly get into the crux of the matter, portal hypertension, rather than hepatocyte failure per se, is responsible for most of the complications. Now, usually patients will say, do I have cirrhosis? They will say, how much is resolved? So actually, the fact is not really the hepatocyte failure, it's portal hypertension, which is the driver of all the complications and the morbidity and mortality. So hepatic venous pressure gradient, we can do invasive, that we have all been taught during our undergraduate time, is the gold standard to measure portal hypertension, because portal hypertension is the problem here, and what we're trying to tackle is this talk. So here we can realize that as the portal hypertension increases, we get complications. So at 10, we get 10 millimeters mercury, you get varices, you got ascites, hepatorenal syndrome, increased risk of decompensation, mortality, recurrently. So here, now they have identified this cutoff, which is more than 10, is considered a crucial watershed moment, and from this point onwards, it has prognostic information about, and for this we call clinically significant portal hypertension. So that's what this topic is about, clinically significant portal hypertension, more than 10 millimeters mercury. So I'm emphasizing this again because the topic really talks about clinically significant portal hypertension. Once we hit the point of 10, you get varices or the complications. So 10 or more is detected as clinically significant portal hypertension. So next, our goal is to try to detect it, and if possible, to treat clinically significant portal hypertension. Now the problem is that what I showed you already is an invasive test. So the holy grail of hepatology has been to find non-invasive tests that we can diagnose. And even simple things like platelet count less than 100 strongly suggest. But actually what we are trying to do is find other measures of cirrhosis, which is actually a histological diagnosis. What we're trying to do is find liver thickness measurements using different modalities. Now, as you can see, there are a lot of modalities available, but transient elastography is the one which is most available. And out of that as well, FibroScan is the one which is most validated and used internationally. So what is a FibroScan? So a FibroScan is like an ultrasound machine, but it's sort of a simple ultrasound machine. It shoots one beam of ultrasound wave, and it goes through the liver, and depending how stiff the liver is, we will get a reading. So this has revolutionized hepatology, because for a change, now we don't have to go behind radiologists begging for early scan days. We can do it ourselves, and you can see how happy the gastroenterologist is in the future. So with this, we get a simple reading. For example, on your left side, you can see a normal liver, and the reading is 3.5 because it is not stiff. whereas in a cirrhotic liver, the reading is 33.3, which is different. So FibroScan is used for two things, not only to detect, first of all, it is used to detect liver fibrosis. So the primary device to find liver fibrosis. And now we are using it as a non-invasive marker to detect clinically significant portal hypertension, which we are talking about today. So just before we go to portal hypertension, we have talked about how we detect liver fibrosis. If we take a patient with fatty liver disease, you can see the disease course will go through 1 to 5, healthy liver, fatty liver, fibrosis, cirrhosis, and cancer. So what happens is now we have a FibroScan or anonymous markers we can monitor, and at one point we will detect patients who have early fibrosis. So this point onwards, patient is at risk of hepatocellular carcinoma, long-term mortality. So this point onwards is defined by this new term, which is compensated advanced chronic liver disease. So what is this? It is a broad term which includes, it is similar to compensated cirrhosis, but because we have modalities to detect early fibrosis, this includes early patients who will have advanced fibrosis, but not overt cirrhosis. So these are the Bevan 6. This is what, when they met last time, what they thought of. So they use these liver cutoffs. Liver stiffness less than 10 rules out compensated advanced chronic liver disease. More than 15 highly suggestive, and 10 to 15 is suggestive. So the next question is you may be running to is, do all patients with fatty liver disease, for example, need a FibroScan? The answer is no. We have other simpler tests and easily available tests such as the PIP4 score, which is a calculation we do with simple basic tests that you can see on a smartphone. And from this, we can either rule out, or if we suspect with higher values, we can refer the patient for a FibroScan. So how does FibroScan help in monitoring clinically significant portal hypertension? So these are cutoffs. Now we can, if the liver stiffness is low and the platelet count is high, more than 150, it rules out clinically significant portal hypertension. Alternatively, if the liver stiffness is more than 25, that per se is sufficient to diagnose clinically significant portal hypertension. We do not need a endoscopy per se to diagnose. And if it's in between these two values, we use these cutoffs, and they are associated with about 60% likelihood of clinically significant portal hypertension. So this is actually a summary slide, which is supposed to make our life easier. So it's called the rule of 5. As you can see, less than 5, it excludes. More than 15, it makes clinically significant compensated advanced liver is more likely. And as we go, it also gives the values for clinically significant portal hypertension, according to Bevan 7. So FibroScan is a new toy. So gastroenterologists like to play around with it. So they don't look at just stiffness of the liver. They also have to check the stiffness of the spleen. And similarly, using these cutoffs, we can use the splenic stiffness to diagnose or exclude clinically significant portal hypertension. Now you may be asking, now what happens after detecting clinically significant portal hypertension? What is the use? If cirrhosis is usually considered a progressive disease and we can't do anything about it. So actually, there are trials which have shown that if the portal hypertension is the driver of the disease, if we reduce the portal hypertension, whether we can reduce the long-term complications. So this is a sort of a new trial called Predisky, beta blockers to prevent decompensation in cirrhosis in patients with clinically significant portal hypertension. So it's a randomized one done in Spain, 8 hospitals, but actually it's only about 200 patients, but their venous specifications have been checked. And what they found is with patients on beta blockers, propranolol or carvedilol were found to have a less incidence of complications, mainly ascites. So on that basis, there is an impression that long-term treatment with beta blockers could increase the decompensation-free survival. We prevent decompensation by prophylactically giving beta blockers. So in this, actually, the question that you may be running to ask is propranolol or carvedilol. So finally, after many, many long years, the ESL committee has agreed that carvedilol is the preferred beta blocker over propranolol We've been using it for many years in Sri Lanka, but here now we do have evidence. Why? Because it's more effective. It reduces pressure in a greater extent. It has better survival, and of course has better tolerability than propranolol. So this is actually a sea change. I hope you appreciate what we're talking about. Previously, only patients who have varices will be given beta blockers. But now with Baveno 7, even if we don't have varices, if we have clinically significant portal hypertension, there is an indication to treat with beta blockers, and this is to prevent decompensation. The next question you may be thinking about is, do all cirrhotic patients still need an endoscopy? The answer is not really. So if a patient who is very compensated, the patient in any case will need endoscopy. But a patient who is compensated, we can check the platelet count and do a fiber scan. There, if the platelet count is more than 150 and the liver stiffness is less than 20, this makes varices very unlikely, and therefore they do not need endoscopy according to Baveno 7. But of course, they need to repeat this non-invasive test yearly. What else can we do in cirrhotic patients? We can remove any etiological agents, rarely. So basically, if it's a hepatitis C patient, removing treatment, or hepatitis B patients, treatment can really improve cirrhosis patients. Similar thing happens when we stop alcohol and the patient goes into a long-term abstinence. Not so important, but still something we have to remember. Weight loss and deal with obesity, diabetes, those are also important things. It won't help as much as patients stopping alcohol completely, but they also have to be addressed in the long-term management. So with the suppression of the primary etiological agents, patients can improve. This is actually termed as a recompensation. Basically, you can have resolution of ascites or diuretic, resolution of hepatic encephalopathy, absence of valvular bleeding. So this is seen after you treat patients with hepatitis C and B, and we have seen this actually even in the periphery. And this is just one of my patients, not the same patient I'm showing, but he had crossed ascites, and on the right side you can see after 6 months of abstinence, ascites is completely resolved, and you can see he's a new patient simply because of abstinence of alcohol. So what are the other treatments that we can give which may benefit portal hypertension? How about statins? Now, everybody used to be scared of statins previously, but now we find that statins should be encouraged in patients with cirrhosis. Encouraged in patients with cirrhosis. Still, there is no indication to give for cirrhosis per se, but they do have an indication of statins. We should really encourage them. And this is because they have been shown to reduce portal hypertension and may improve overall survival. So we must have a low threshold starting statins. There is any indication. So is it safe in decompensated cirrhosis? We need to monitor more carefully. And if it is child B or C, we can still give statins, but we should give maybe a lower dose. And simvastatin is the one which has been used predominantly. How about aspirin? Right? So normally a lot of people will run away from aspirin with cirrhosis. The platelets come down, but in early cirrhosis, we should not discourage patients from taking because it has been shown to reduce the risk of hepatocellular carcinoma, reduce liver-related complications as well. Of course, post-banding, we have to be careful because there's a risk of post-banding ulcer. There has been a controversy about giving albumin because some trials are there which show that recurrent albumin infusion may be beneficial, but there's alternative evidence that shows that there is no benefit. So at the moment, with the Baveno 7 stays away from this discussion and says there is no evidence to recommend either way. But of course, we know what we should definitely give albumin, which is for spontaneous bacterial peritonitis, acute kidney injury, if we do a large volume paracentesis, and also hepatorenal syndrome combined with telepathy. So other treatment that you can save the life of the patient prophylactically would be to give SPP prophylaxis. If they have had SPP, of course, we give prophylaxis. Also, as you know, now there are patients who may need primary prophylaxis. What this is if patients have ascites and have very low levels of albumin, low levels of protein in the ascitic fluid, they are at higher risk of bacterial translocation and spontaneous bacterial peritonitis. So we treat them with norfloxacin, but it's only for patients who have severe disease defined by child weight more than 9, bilirubin more than 3 with renal impairment. of course, who should we give rifaximin to long term, which is for patients who have had hepatic encephalopathy, and we can use it like antibiotic prophylaxis to prevent recurrent hepatic encephalopathy in patients who have already had hepatic encephalopathy. So a few words about acute variceal bleed. As you can see, these are all patients from Kalutara, and they are as dramatic as they appear on your screen. Yeah, so this is actually a video. As you can see, I just show the point. There's a bleeding point at 12 o'clock position, and you can see that blood is squirting from that position. And I hope you will appreciate. I don't have a pointer here. You can see that. At the top, blood is just pouring out. So this is the real acute variceal bleed, and we have to know how to take care of it and how to save the lives of our patients. So not many new things in Baveno 7. Volume resuscitation is important. We have to give volume re-expansion and to maintain the hemodynamic stability. I've seen so many patients in A&Es just with a drip going slowly. It's just not going to make it. If you have a patient who's bleeding like I showed you in this video, you can appreciate how much fluid we have to give and maintain that patient's blood pressure till we can get in and stop the bleeding. Yes, we have conservative levels for transfusion, 7 to 8, but this is in a stable patient, and also we have to take other factors like age, hemodynamic status, and we have to reassess if there is ongoing bleeding. Antibiotic prophylaxis with ceftriaxone is life-saving, just like endoscopy, and also intubation if the patient altered consciousness. Of course, in Sri Lanka, this is a fantasy, as I think most of our audience will appreciate. But what we can do is urgent endoscopy. Now, this is the same pictures of the same patient that I have shown in the video. And you can see that the vessel is just squirting and there's continuous bleeding. So although upper GI should be done within 12 hours of presentation, this is not a rule. So that is, if the patient is unstable, it should be done as soon as possible to save, because this patient actually, we have banded, and we banded within about 4 or 5 hours, and he did fine. But I don't think he would have survived if he had waited for overnight or for 12 hours with that rate of bleeding. A few new things. Pre-endoscopy, erythromycin is helpful to give us a clear field, and ideally we should have a 24-hour team which is able to handle such cases. Although I think clearly in the current scenario, it's really becoming more fantastic. Well, we should treat with band ligation. So I hope you appreciate that ligation has been done, and we have caught the bleeding site of the varix. It's very, very important, because just going and putting bands where you can see is not going to help. We need to find the site of bleeding and get a band to close the bleeding. And of course, for fundal varices, we do synovial for IgV2 one type varices. You can consider ligation or tissue tube. And there's a new thing of hemospray which we use in Sri Lanka as well. It cannot be recommended as a first-line therapy, according to BAM. Few small things about acute variceal bleeding. Nutrition status is worst prognosis. Therefore, oral nutrition we should try to start as soon as possible. And also, this is a very useful guideline. All patients who have acute variceal bleed should undergo abdominal imaging, ultrasound, ideally CT, because at that stage they have suddenly decompensated. So that may be due to hepatocellular carcinoma or portal vein thrombosis. So we need to do abdominal imaging as part of the workup of an acute variceal bleed patient. How about acute variceal bleed and encephalopathy? Now, you know that the moment patient bleeds, very soon, in a few hours, within the day, that may precipitate encephalopathy. And if the patient becomes unconscious, it becomes difficult. We can't put a tube to do the endoscopy, and next patient will have aspiration pneumonia and die. Match over. So we have to really on the ball to get the endoscopy early, stop the bleeding, and treat encephalopathy if he is going into encephalopathy. So Baveno 7 recommends lactulose as well as enemas, and it encourages the rapid removal of the blood from the gastrointestinal tract, will prevent the septic. Of course, if your patient has had variceal bleed, it's very important. We should give them a combination of beta blockers, usually carvedilol, and recurrent variceal bleed band ligation on a variceal eradication program, not just one. So all good things going into AKI, this is not the time to continue beta blockers. I have seen so many patients still on carbidopa, high doses. When the blood pressure is starting to drop, creatinine is going up, then it's the time to stop beta blockers and go into a banding program to make sure the patient doesn't bleed as a result. Of course, if they improve, of course, we can restart it. There's one more concept to I quickly cover, something called further decompensation. Further decompensation is represents a prognostic stage with an even higher mortality than first decompensation. So this is how it's defined. If the patient has a second portal hypertension given decompensating event, like the second ascites, varicose bleed, hepatic encephalopathy, or going late into jaundice, it's considered further decompensation. If the patient has recurrent varicose bleeding, recurrent ascites, recurrent encephalopathy, this is also further decompensation, and has very poor prognosis. And also patients say they came with bleeding, but as the bleeding was improving, at a late stage they go into ascites or jaundice. So that is also defined as called further decompensation, and actually patients really need to be considered for transplant and further management. So this is actually an overview of Webeno 7, and as you can see, it has made life a little bit more complicated for those who are trying to understand the field. So this is the phase of late further decompensation, and the patient can deteriorate. So very few take-home messages. Portal hypertension, rather than hepatocyte failure per se, is responsible for complications and the mortality. Clinically significant portal hypertension, that pressure greater than 10, has prognostic significance. It may be detected early with new non-invasive methods, including fibroscan. These patients should be considered for treatment early with carbidopa as a first-line therapy, which may prevent them from going further and decompensate. And statins are friends, not foes. So I think I'm on time, and I would like to gratefully acknowledge Professor Anurag Desanayake, Professor Madhurendra, and Dr. Nilanga for their help and assistance in this presentation. Thank you very much.
Thank you. Thank you very much, my very dear friend, Dr. Mananjara Seranayake. There is one question. I will just take one question. Are proton pump inhibitors indicated following variceal bleeding? Mananjala, if you can give your answer to that, please. Thank you.
Yes, I think in our setting, it is indicated. I think it is indicated. Internationally, there is a trend to stopping proton pump inhibitors. I think that there are different reasons. There may be site-specific spontaneous peritonitis and things like that. But yeah, it's a controversial topic. But personally, I think it is indicated because in our setting, we do, in the Webeno guideline, actually, they don't encourage the use of omeprazole. They say that they sort of discourage use. However, I don't think we have to accept everything per se. After banding, we see lots of patients who get post-banding are bleeding. I mean, for a year, I have seen about 3 or 4. So we feel strongly, as I think the whole gastroenterology community, I think, is behind this, that we should be giving proton pump inhibitors, not indefinitely by any means, but for the first 2 weeks, I would give for the first month, because there is a risk of post-banding ulcer. When the band falls, you get an ulcer on the varices. So sometimes patients do bleed, and though we think it's a minor bleed, rarely patients can have terrible consequences. So I would encourage definitely to give, but I acknowledge that worldwide there is a movement to not giving PPIs, and definitely we should be giving PPIs unnecessary for patients long term for sure. It's mainly in the post-banding stage that we should give. I hope that is reasonable. My friend Hassan might have to maybe to add more to that. But,
right, thank you very much. So we wish to present you with a certificate of appreciation, Dr. Seranayake. Thank you very much for joining this program today. I'm very grateful. And then it is my pleasure to invite the next speaker, Dr. Hasitha Vijayavantha. He's a gastroenterologist from Teaching Hospital Ratnapura. Hasitha, over to you. Please take over. Thank you very much.
First, I will discuss about the name change and the circumstances which led to it, because it's a current topic and the heated debate in the field of gastroenterology, and followed by, after that, I will discuss optimizing management for maximum benefit in non-alcoholic fatty liver disease. This disease was first described by the famous American hepatologist and physician Gerald Clatstein. It was presented in annual meeting of the American Association of Study of the Liver in 1979. Subsequently, this name of non-alcoholic steatohepatitis was given by Ludwig and colleagues in his publication in Mayo Clinic Proceedings. So, what is non-alcoholic fatty liver disease? It's presence of steatosis in more than 5% of hepatocytes in the absence of significant alcohol intake and in the absence of no other non-liver diseases. So there are two categories: non-alcoholic fatty liver disease when there is no evidence of hepatocyte injury or inflammation, and non-alcoholic steatohepatitis, it is a histological diagnosis when there is more than 5% steatosis with inflammation, hepatocellular injury with or without fibrosis. So key features are absence of unsafe alcohol consumption, absence of other competing etiologies for hepatic steatosis such as drugs, etc., no other coexisting liver diseases, and it is divided into two main entities, steatosis with inflammation and steatosis without cellular injury or inflammation. That is called NAFL and NASH. So because of the deficiencies in this definition, the name, there was an urge, especially in the Western hepatologists, to change this name from the early 2000s. And as a result, in 2020, these worldwide experts came up with this paper with the suggestion and proposal to change the name from non-alcoholic fatty liver disease to metabolic associated fatty liver disease. Subsequently, name was slightly modified to metabolic dysfunction associated fatty liver disease. So what is metabolic dysfunction associated fatty liver disease? That means hepatic steatosis diagnosis by imaging techniques, blood biomarkers or scores, or by histology in a patient who is overweight or has diabetes. When the patient does not have obesity or diabetes, then he or she should have components of metabolic syndrome. So in short, the steatosis in a patient who either have obesity, metabolic syndrome, or diabetes mellitus. So what are the components of metabolic syndromes? Waist circumference, blood pressure, plasma triglycerides, low HDL, pre-diabetes or impaired glucose tolerance, insulin resistance, and systemic inflammation as evidenced by high sensitivity CRP level more than 2 milligrams per liter. So these are now this slide shows the differences between NAFLD and NAFLD. As I discussed earlier, NAFLD is basically a diagnosis of exclusion of alcohol intake or other competing etiologies. So no requirement for metabolic dysfunction, and it cannot, as per its definition, it cannot coexist with other liver diseases. So liver biopsy is required for diagnosis of NASH. It's one of the main deficiencies in this name and the definition. So what about metabolic associated fatty liver disease or metabolic dysfunction associated fatty liver disease? The inclusion criteria includes overweight or obesity, type 2 diabetes mellitus, metabolic dysfunction, and most importantly, it can coexist with other chronic liver diseases such as hepatitis B, hepatitis C, alcohol, and autoimmune hepatitis. So independent from alcohol intake and no requirement for liver biopsy. It's a spectrum of disease, and disease severity would depend on from stage to stage, and there is no dichotomous entities such as non-alcoholic fatty liver and fatty liver steatohepatitis. But so fatty liver fat deposition in liver and fat deposition and inflammation in the liver is multifactorial. Not only metabolic syndrome, it is affected. The etiological factors are insulin resistance, genetic factors such as PNPLA3, bile acids, gut dysbiosis, circadian clock, environmental stresses, and so many other things which we even don't know yet. So, and also, as you can see in this cartoon, when the classic metabolic syndrome is only one factor which contributes to fat in the liver, and lipodystrophy, infections, xenobiotics such as tetracycline, malnutrition, chronic inflammation, defective metabolism like in Rye syndrome, trans-antagonist excess, all those things can cause fatty liver disease. So after the invent of this new term, MAFL, now people with fat in the liver were divided into 3 groups. First category is non-alcoholic fatty liver disease, which do not qualify criteria to be diagnosed as MAFL. Second category, the overlap group. The third category is the people who qualify the criteria for metabolic dysfunction associated fatty liver disease and who do not have fulfilled the criteria of NAFL. So now, after some time, even some of the authors of the original paper and consensus document realized that this name has so many, now name suggestion, even the name suggestion has so many deficiencies. So now this is the second paper from NAFL to MAFL, the implications of premature change in terminology. 8 out of the 4 authors in this document are authors of the first consensus document as well. So now, so then they changed, they came up with this paper and with their comments that now there are so many negative features in the new terminology MAFL as well. To sum up what we have discussed so far, there are still significant gaps in knowledge on diagnosis, natural history, and treatment. NAFL is a heterogeneous condition. We may never be able to assign a single name for a disease as heterogeneous as NAFL. Name change is not based on new knowledge on pathogenesis, risk stratification, molecular phenotyping, or therapeutic approaches. So, however, as the debate goes on, just like anything else in this world, the balance is tipped towards eminence rather than evidence. So, finally, to conclude, now non-alcoholic fatty liver disease has so many deficiencies. It's a diagnosis of exclusion, and it has so many emphasis on alcohol, which is sometimes not true. However, the NIM terminology, metabolic dysfunction associated fatty liver disease, also has so many insufficiencies. So MAFL is yet another inadequate terminology which needs to be redefined as we improve our understanding of the condition. So I will keep on the term old name. I will discuss this condition here from now onwards as non-alcoholic fatty liver disease. So what are the outcomes of non-alcoholic fatty liver disease? Increased overall mortality. It is the commonest cause of death in patients with non-alcoholic fatty liver disease is cardiovascular. Higher incidence of liver-related outcomes. Third commonest cause for hepatocellular carcinoma. Increased incidence of non-liver cancers. Coexisting diabetes increases the prevalence of NASH and advanced fibrosis. Presence of increasing number of components of metabolic syndrome increases the incidence of advanced fibrosis. And most importantly, 11% of incidentally discovered patients with fatty liver may be at risk of advanced fibrosis even at the time of finding, according to NAFL fibrosis score. So fibrosis is one of the main determinants of mortality in patients with non-alcoholic fatty liver disease. It affects all-cause mortality and liver-related mortality also. As the fibrosis stage advances, mortality also goes up. So how do we detect fibrosis? Now, Mananjala discussed this in detail. These are the serum markers. These are transient elastography. It's an ultrasonic-based physical investigation. So out of these serum markers, FIB4 index and NAFL fibrosis score has been found to be better in predicting early fibrosis in patients with non-alcoholic fatty liver disease. So FIB4 calculators are available as apps and even in your smartphone. In fact, this is a screenshot of my phone. And if you fill these cages, your app and phone will automatically calculate the FIB4 value. So if the FIB4 value is less than 1.45, it's unlikely to have advanced fibrosis. And if the value is more than 3.25, are likely to have advanced fibrosis. In between, patients needs further investigation. Other indirect markers of advanced fibrosis, AST more than ALT, thrombocytopenia, splenomegaly on ultrasound scan of a patient with non-alcoholic fatty liver disease. Fibrox scanned evidence of advanced fibrosis. However, it's not freely available in the periphery, and even in Colombo only few centers have fibroscan. As Mananjala explained, the liver stiffness measurement more than 10 confirm implies that there is advanced excludes less than 10 excludes advanced fibrosis, more than 50 confirms advanced fibrosis. However, as you can see, even at values around 7, there can be F1 fibrosis. So Mananjala discussed advanced fibrosis. Now what I am talking about here, F1 early fibrosis. So even at liver stiffness level of 7, you can have F1 fibrosis. So when to do liver biopsy? To rule out competing etiologies when assessment of underlying liver disease is not possible without a biopsy. It is very important these biopsies are interpreted by a pathologist who has a special interest in liver histology. So goals of liver biopsy to confirm or exclude the diagnosis and assess the severity of the disease, whether it is non-alcoholic fatty liver or whether it is non-alcoholic fatty liver with some degree of inflammation, and whether it is full-blown non-alcoholic steatohepatitis. To stage the disease, staging means that to objectively assess the degree of fibrosis, and grading means to assess the objective assessment of the necroinflammation. So NAFLD therapy. So treatment of NAFLD involves treating the underlying liver disease as well as associated comorbidities. As most of you all would have seen, non-alcoholic fatty liver disease that does not exist on its own. It is most of the time it is associated with other comorbidities. So promote weight loss by diet and exercise, control of main cardiometabolic risk factors, correction of modifiable risk factors associated with progression of NAFLD, prevention of hepatic and extrahepatic manifestations, avoid and prevent other potential causes of hepatocyte injury. In our setting, commonest cause is hepatitis A, and we don't have hepatitis B that much. So anyway, when you diagnose a patient with fatty liver disease and who is at risk of further fibrosis, it's always a good practice to offer them hepatitis A and B vaccination and avoid hepatotoxic medication, especially ask the patient do not take herbal medicine and herbal drinks, especially collagen. So what is the preferred diet in non-alcoholic fatty liver disease? Mediterranean diet has the highest evidence in non-alcoholic fatty liver disease. It's a low cholesterol, saturated fat, low cholesterol and low saturated fat diet, high monounsaturated and polyunsaturated fatty acids, and higher content of omega-3 fatty acids and low omega-6 to omega-3 ratio, moderate amount of fish and white meats. So reduction of calorie intake by 750 to 1000 kilocalories per day results in improvement of insulin resistance and fatty liver. And unsweetened coffee may have beneficial effects. Refined sugar and high fructose corn syrup should be avoided. And most importantly, alcohol should be avoided. There is no safe limit. New evidence suggests alcohol has a synergistic detrimental effect on the liver along with metabolic syndrome. Alcohol is likely to have a dose response effect rather than a J-shaped association as previously we thought. So the other thing is now excessive fructose consumption can lead to addictive behavior. Now, ladies and gentlemen, be watchful to see whether your children are fructoholics. If it can cause addiction and ultimately can lead to fructoholic liver disease, just like alcoholic liver disease, especially in children. So weight loss. So weight loss of more than 5% improves steatosis. Weight loss of more than 7% improves NAFLD activity score. And weight loss of more than 10% improves all components of non-alcoholic steatohepatitis, including portal inflammation and fibrosis. So our target should be to advise our patient to lose more than 10% of their baseline body weight with diet and exercise and lifestyle modification. So what are the benefits of exercise in non-alcoholic fatty liver disease? Physical activity reduces the risk of type 2 diabetes mellitus, insulin resistance, hypertension, dyslipidemia, impaired fasting glucose, and metabolic syndrome. And this trial, published in Hepatology way back in 2009, has shown that irrespective of the degree of weight loss, people who engaged in physical activity more than 150 minutes per week, and those who increased their physical activity from the baseline by more than 60 minutes per week had improved liver functions, improved serum ferritin, and improved all metabolic variables except 2-hour postprandial blood sugar levels after 3 months. So exercise is beneficial irrespective of the weight loss in non-alcoholic fatty liver disease. Now, now I'll move on to the pharmacotherapy. This is a slide. This is a table from famous Pivens trial about the effect of pioglitazone and vitamin E on NASH patients. As most of you all would know, only vitamin E is the primary outcome. However, both vitamin E and pioglitazone reduce hepatocyte ballooning, lobular inflammation, and steatosis. Both agents did not reduce fibrosis. Both agents improved AST and ALT level. In the pioglitazone group, there were a significant increase in weight. It's one of the main disadvantages of pioglitazone: fluid retention, osteoporosis, and weight gain. Those are the disadvantages of pioglitazone. And vitamin E, there was not much of improvement in insulin resistance. So now pioglitazone improves liver histology in biopsy-proven NASH in patients with and without diabetes. Now this study was conducted in non-diabetic patients. As you can see, it reduces, now negative value means improvement, positive value means increased. So the pioglitazone has improved steatosis, lobular inflammation, liver injury, and fibrosis when compared to placebo. So as Mananjana has already discussed the importance of statins in portal hypertension. Statins has been shown to be beneficial in non-alcoholic fatty liver disease as well. Statins decrease the risk of non-alcoholic fatty liver disease and the risk of liver fibrosis once non-alcoholic fatty liver disease. It is the result of this, one of the major landmark studies involving more than 11 million people of South Korea. It was published in American Journal of Gastroenterology. And statin use was protective for full spectrum of liver damage in individuals at risk of NASH. However, certain genetic variants like PNPLA3 risk variants limited this beneficial effect. This again proves that it's not only the metabolic syndrome and the fat deposition and degree of inflammation. There are certain genetic variants which could influence the response to therapy and progression. So these are some of the new agents and anti-diabetic agents which have been shown to be beneficial in the management of non-alcoholic fatty liver disease. GLP-1 receptor agonists, liraglutide and semaglutide, it has been shown to show NASH resolution. However, not shown any effect in reducing fibrosis. SGLT inhibitors, empagliflozin is the drug which is available in Sri Lanka. It has shown to improve liver profile. And FXR agonist, obeticholic acid, is one of the new drugs which is in the development and hopefully soon will be available in the market to be used in NASH patients. And it has been shown to improve inflammation as well as fibrosis as well as and the liver functions. One of the main disadvantage of obeticholic acid is the elevation of low density lipoprotein level, LDL cholesterol, which is one of the major cardiovascular risk factor. However, now trials are being conducted in combination with statins and obeticholic acid, and also newer generation synthetic obeticholic acid derivatives, SXR agonists, are being studied which do not have LDL raising effects. So bariatric surgery in non-alcoholic fatty liver disease, there are no randomized control trials on bariatric surgery in NASH. It reduces weight and improves insulin sensitivity, diabetes, hypertension, dyslipidemia, and obstructive sleep apnea. Some studies have shown biopsy-confirmed resolution of NASH and fibrosis. However, it is still not recognized as an established specific treatment method for NASH. And at present, bariatric surgery is only indicated in patients with NASH who are otherwise eligible for bariatric surgery. So finally, when to refer for specialist care? Presence of multiple components of metabolic syndrome, as I explained to you all earlier, it is a risk factor for advanced fibrosis and abnormal liver biochemistry. Most of the time, non-alcoholic fatty liver disease patients do not have high non-alcoholic fatty liver without inflammation do not give rise to high transaminases. So if the patient has transaminases more than 2 times the upper limit of normal, or any evidence of polystasis, high bilirubin or alkaline phosphatase, you should be able, patient should be referred to a specialist. Suspicion of advanced fibrosis, appearance of ankle edema is the commonest presenting complaint of our NAFL patients with cirrhosis. So be watchful when you see a patient with non-alcoholic fatty liver disease patient for the signs of chronic liver disease. And thrombocytopenia, AST more than ALT, splenomegaly on ultrasonography. FIB-4 score, as I explained to you all earlier, it can be easily calculated. If the score is more than 1.25, please refer the patient for specialist care. And evidence of coexisting liver disease, transaminases more than 5 times the upper limit of normal. Even though patient have non-alcoholic fatty liver on ultrasonography, if transaminases are more than 5 times the upper limit of normal, it is unlikely to be, it is due to steatohepatitis. So please refer the patient to a specialist care. Clinical jaundice or high bilirubin, high globulin or elevated inflammatory markers suggest an autoimmune etiology. Positive autoantibodies, positive viral markers, serum ferritin more than 1.5 times the upper limit of normal with high transferrin saturation, history of hepatotoxic drugs or herbal medicine use, and problematic alcohol use. All these are indications for specialist care. So this flow chart is the guidance given by the European Association for Study of the Liver. Now, when the patient has metabolic risk factors, ultrasound scan should be conducted. If there is steatosis, do liver functions and calculate FIB-4 score. If the patient is low risk, then you can follow the patient up again in 2 years. If there is in between, between 1.25 and 3.45, the specialist referral. Anyway, if there is high risk, needs to be referred to a specialist. And steatosis is absent, then normal liver enzymes follow up in 3 to 5 years. Steatosis is absent, however, patient has abnormal liver enzymes, then again needs specialist attention to this patient. So now these patients can be further evaluated with non-invasive markers, liver biopsy, and further serological markers. So that is the flow chart given by the European Association of Study of the Liver. Thank you very much.
Thank you very much, Dr. Hasita. Just wait till I on my video. Thank you very much. I'm very grateful for that very informative talk. There is one question. Give me a second. I will put that to you. First question is, what is the dose and duration of vitamin E therapy?
So the trial that I discussed here was Piven's trial. The dose that was used was 800 international units daily, and there was no specific duration mentioned. And the trial was conducted, I think it's for about duration of 3 years. Now there have been certain concerns about the safety of the vitamin E, but it has not been substantiated by subsequent studies. I mean, so the dose is 800 international units daily. It can be given as 400 international units twice daily or twice daily. So dose is 800. And I can see the other question as well.
All right, okay. If you that an answer, that will be very good. Yes.
Yes. So fish oil, omega-3 fatty acids. I mean, that is what is meant by fish oil, I suppose. So fish oil, omega-3 fatty acids has some benefits in cardiovascular diseases and in patients with dyslipidemia, but it has not shown any benefit in non-alcoholic fatty liver disease, and it is not recommended in guidelines. And the other question is metformin. Metformin improves insulin sensitivity and it improves liver profile. However, it has not been effective in improving any components of the non-alcoholic steatohepatitis or improve fibrosis. So only for NAFLD, metformin is not recommended. However, in a patient with metabolic syndrome and diabetes, metformin is very beneficial. And there's another question I can see. What is the place for Hepacol and Oblivia? I would say no. I don't know what is Oblivia even. Hepacol is is a vitamin supplement, and it is basically commercial use. So there is no scientific evidence.
Yeah, and then we will move on to the next talk. May I present you your certification of a
Thank you. So I would first of all like to thank Ceylon College of Physicians as well as Sri Lanka Society of Gastroenterology for giving me this opportunity. Today, the topic will be on management of hepatocellular carcinoma in 2022. So the overview of my talk is first on epidemiology, then pathogenesis of HCC, diagnosis, staging, management, and surveillance and prevention of hepatocellular carcinoma. So with regards to epidemiology, liver cancer is the sixth leading cause of cancer worldwide, and it is the third most important cause of cancer-related death worldwide. So this just gives a perspective on why hepatocellular liver cancer is so important. Then HCC, hepatocellular carcinoma, accounts for more than 90% of primary liver cancers. And underlying liver disease is the most important risk factor. Hepatitis B virus as well as hepatitis C virus is the most important risk factor worldwide, followed by NAFLD, which is probably more important in our setting, and alcohol-related liver disease as well as aflatoxin. Then briefly touching upon the pathogenesis of hepatocellular carcinoma. So in cirrhosis or chronic liver disease, it's a field change which leads to the development of hepatocellular carcinoma. And as you can see, chronic hepatitis, advanced fibrosis, cirrhosis, and from then on, the risk of hepatocellular carcinoma increases. So this is important in prevention, primary or secondary or tertiary. And the potential strategies to prevent HCC, I will touch upon later. But I have to note here that 25% of cases occur in the absence of chronic liver disease. So diagnosis of hepatocellular carcinoma, in the background of cirrhosis, hepatocellular carcinoma can be safely confirmed non-invasively by imaging. However, in the absence of cirrhosis, the diagnosis should be confirmed with histology. Non-invasive image assessment is only useful if the lesion size is more than 1 centimeter, and multiphasic CT or dynamic contrast MRI is the preferred imaging modalities, and these are preferred over contrast enhanced ultrasound. Then sorry, there's a spelling mistake. It's FPG, PET, not recommended in the early diagnosis of hepatocellular carcinoma because of a high false negative rate. Then with regards to diagnosis, like I've said earlier, if the lesion is more than 1 centimeter as detected on ultrasound surveillance or ultrasound done for symptoms, then for confirmation of the diagnosis, multiphasic contrast enhanced CT or MRI can be done. And if either of these, not both of these, and if there's positive findings on the imaging, if that's confirmatory of HCC, then you can proceed with management of the lesion. However, if it is non-confirmatory, depending on which imaging modality was used earlier, then the second imaging modality can be used to see if the confirmatory findings are present. And if it's diagnostic, then of course it's HCC. However, if the confirmatory imaging findings are absent, then there's a place to proceed with biopsy. Then about lesions which are less than 1 centimeter in size, a repeat ultrasound should be done at 4 months. And if the lesion is stable in size, this can be repeated in another 4 months. So if it's a cirrhotic patient who undergoes surveillance ultrasound, after 1 year of repeated ultrasounds and the lesion is stable, then you can go on to routine surveillance, which is 6 monthly. However, if the lesion changes in pattern or if the lesion is growing, then you move on to either CT or MRI. Then about LIRADS, a lot of you might have seen this being reported on the CT or the ultrasound, CT or the MRI. So LIRAD 5 is the one which is confirmatory of CT. I'm not going to go into much detail on this, but this is the probability, the diagnostic probability of the hepatocellular carcinoma according to imaging. Then what are treatment options available for hepatocellular carcinoma? First off, this is the most curative option available, liver transplant, which can be through a live donor or a cadaveric donor. Then hepatectomy, resection of the lesion. It can be either anatomical or non-anatomical. Then ablation, TACE, transarterial chemoembolization, which are more palliative than curative. Then TAR, transarterial radioembolization, and systemic therapy, again palliative, multikinase inhibitors, immune checkpoint inhibitors. Then hepatectomy. So this is the decision to go ahead with hepatectomy will be decided by the presence of the liver function, the function of the liver, of the residual remnant liver, as well as the presence of portal hypertension. Then percutaneous ablation, there are mainly two methods available, radiofrequency ablation, microwave ablation, and ethanol ablation is also available. However, radiofrequency ablation and microwave ablations are the preferred modalities with probably better performance of microwave ablation over radiofrequency ablation. Then staging of hepatocellular carcinoma. This is important for treatment allocation. Prognostic assessment is complicated by the underlying liver disease, unlike most other solid malignancies. TNM classification has minimal value in hepatocellular carcinoma. Then we have the alternative BCLC. There are a lot of staging systems, but BCLC, Barcelona Clinic Liver Cancer System, is the most widely used and the validated. It is based upon the tumor burden, liver function, which is assessed through child score or MELD, but these are not ideal. Albumin bilirubin scoring has a place. This is used mainly to classify child A into further prognostic groups. And then performance status. ECOG scale is used here. I must also mention the performance status mentioned here. The ECOG scale is the performance status due to the malignancy, not the pre-morbid performance status. Then this is the ECOG scale. It is from 1 to 6. Then treatment decisions. And a MDT-based, multidisciplinary team-based approach is essential, which is guided by the BCLC system. However, it's important that it's an individualized decision depending on the age, the comorbidities, as well as the choice of the patient. And tumor board should include a hepatologist, oncologist, GIO, HPB surgeon, and an interventional radiologist. So this is in one diagram what the BCLC approach is. So I will go into detail on what each of these is, but I want to show here that from very early stage BCLC 0 to advanced stage BCLC C, that all of these have preserved liver function. That's a requirement for treatment. And the other thing is with terminal stage, with advanced liver disease, the prognosis is very poor. So BCLC 0, not very early stage, is a solitary tumor less than 2 centimeters with preserved liver functions, no vascular invasion, no extrahepatic spread, no tumor-related symptoms. So performance status 0. Then if the patient is for liver transplant, hepatectomy is the ideal solution. This is because then if the patient is not for liver transplant, then the option is ablation. So the recent ablation is a cheaper alternative as well as relatively non-invasive. But the reason to recommend hepatectomy is because of the availability of histopathology. And if there's microvascular invasion in the hepatectomy histology specimen, that will lead you towards liver transplantation. So that's why it's the preferred option for patients who have the option of liver transplant. So both RF radiofrequency ablation or microwave ablation is the preferred. Ethanol ablation only if technically not possible to go ahead with the radiofrequency ablation or microwave ablation. Then BCLC-A, early stage. What's changed here from BCLC 0 is solitary hepatocellular carcinoma, irrespective of size. Earlier, it was only lesions less than 2 centimeters in size, and multifocal hepatocellular carcinoma up to 3 nodules, none more than 3 centimeters. So I will later go on to explain why they've used this criteria. This is the Milan criteria. Then again, no macrovascular invasion, no extrahepatic spread, no cancer-related symptoms, and preserved liver functions. Then out in this category, solitary hepatocellular carcinoma. So I've actually simplified the management of solitary hepatocellular carcinoma. This is probably an oversimplification, but this is much easier to understand. If a solitary hepatocellular carcinoma, you check for clinical significant portal hypertension or raised bilirubin. And in the absence of these, hepatectomy is the ideal solution. And if clinical significant portal hypertension or raised bilirubin is present, then liver transplant is an option. Then liver transplant is the ideal solution. But if not for liver transplant, ablation would be the next step. And if ablation is also not possible, there's something called tumor stage migration. So even if the patient is in BCLC-A, then the patient needs to be migrated to the next stage, and case or tear should be considered. Then resection in the absence of clinical significant portal hypertension, like I've said, and liver transplant is the preferred option in the presence of clinical significant portal hypertension. However, there is a place for laparoscopic resection in the background of minor clinical significant portal hypertension if liver transplant is not a feasible option. Ablation is limited by the size of the hepatocellular carcinoma. Most of the time, if the lesion is more than 2 centimeters, this is less effective. However, tear or TACE can be considered for solitary nodules, and tear only if the lesion size is less than 8 centimeters. And these treatment options can be considered while awaiting liver transplant if the waiting time exceeds 6 months. Then about multifocal HCC, still within BCLC-A, if they are within Milan criteria. So that's the reason why they included the lesion size as well as the lesion number. So Milan criteria is the recommended criteria that should be present to decide on liver transplant or to go ahead with liver transplant. A single lesion less than 5 centimeters or less than 3 nodules, each less than 3 centimeters. Ablation and resection, there's a high risk of recurrence. So multifocal lesion, if they are within Milan criteria, liver transplant is the best option. Then BCLC-B, intermediate stage. What's changed from the other criteria is the presence of multifocal hepatocellular carcinoma, but outside Milan criteria. And again, no vascular invasion, no extrahepatic spread, preserved liver functions, no cancer-related symptoms. This is a very heterogeneous group. Prognosis is influenced by alpha-fetoprotein levels as well, and increased bilirubin more than 2 milligrams per deciliter or fluid retention, needing diuretics. This patient needs to be stage migrated into BCLC-C. So if the lesions are well defined in BCLC-B, they can be still for liver transplant. In some centers, they have extended liver transplant criteria. However, this is probably not recommended in our setting. Alpha-fetoprotein more than 1000 nanograms per deciliter is an exclusion criteria for liver transplant in most centers. Then, what about the patients who are not for liver transplant but have well-defined nodules? TACE for well-defined nodules has a place in this. conventional TACE using chemotherapy. Doxorubicin is what we use here, emulsified in lipiodome, followed by gel form. Then diffuse HCC with no well-defined nodules, extensive liver involvement, increased bilirubin or fluid retention needing diuretics, no benefit from TACE. They needed to be considered for tumor stage migration, like I mentioned earlier. So they might benefit from systemic therapy. Then BCLC-C, this is advanced stage, and irrespective of the tumor burden, in the presence of vascular invasion or extrahepatic spread, preserve liver function. Again, so like I mentioned earlier, from BCLC node to BCLC-C, it's preserved liver functions. They might have tumor-related symptoms as well. So this includes any patient in the previous stages who will not benefit or in whom the treatment recommendations are not feasible. So systemic therapy, there was a 2022 new update from the BCLC, which was, there was a review article in Journal of Hepatology, and now the first line systemic therapy, the preferred option is atezolizumab plus bevacizumab. So we have bevacizumab, it's a monoclonal antibody, anti-angiogenic factor, but atezolizumab is a immune checkpoint inhibitors. You might have heard of immune checkpoint inhibitors. These are recently used in a lot of cancers, which were untreatable by most other therapies, including non-small cell lung cancers and squamous cell malignant skin malignancies. However, they are very, very expensive, and most of them are not available in Sri Lanka, and they have only a survival advantage of about 2 to 3 months compared to sorafenib. Then sorafenib is what we have been using up to now as first line as systemic therapy, but the problem with sorafenib is most of our patients are intolerant to the effective dose. So there are a lot of side effects from sorafenib. And even the survival advantage with sorafenib, which is again an expensive drug, is low. So BCLC at the end stage. So this is irrespective of hepatocellular carcinoma burden. If the patient has impaired liver functions and when liver transplant is not an option, and they might have major cancer-related symptoms. So this includes a broad group of patients in whom the liver functions are impaired, but their hepatocellular carcinoma might be at any stage from a less than 2 centimeter one to a multinodular hepatoma. The treatment for HCC in this group will not change the expected survival due to the underlying liver disease. Palliative care with symptomatic management is the ideal solution in them. So the other thing I need to mention here is if the patient has, let's say, a decompensated cirrhotic patient or a child C patient undergoes ultrasound and there is no liver transplant plans and you detect a hepatoma, there is no point in going ahead and doing CT or MRI to confirm the presence of a hepatoma, because this is not going to change the management. Then best supportive care, paracetamol less than 1 grams per day for mild pain. NSAIDs should be avoided, especially in the background of cirrhosis. Opioids can be used, but constipation should proactively be managed. And in patients with advanced cirrhosis, we have to be careful with psychoactive drugs, especially benzodiazepines. And bone meds, there might be a place for palliative radiotherapy. Then adequate nutrition should be addressed. So assessment of response should be done with imaging, CT or MRI. Then there are other MRECIST and RECIST 1.1 calculators we use to assess the response. Then progression after treatment. Growth more than, so it might be the patient might have been in BCLC-B or BCLC-C. So the progression might be the presence of a new lesion or the increase in size of an existing lesion. So there are progression, which is untreatable, or progression with stage migration. What about surveillance? So all cirrhotic patients, child A and B, should have surveillance. Any child C patient awaiting liver transplant should also have surveillance. Non-cirrhotic hepatitis B virus patients at intermediate or high risk of hepatocellular carcinoma should have surveillance. However, like I mentioned earlier, child C patients not for liver transplant, there is no place for surveillance. So by surveillance, I mean ultrasound done by an experienced radiologist every 6 months, combined with serum alpha-fetoprotein levels every 6 months. So there's some controversy on the use of alpha-fetoprotein levels. However, the latest ESO guidelines recommend the use of alpha-fetoprotein levels. So prevention is mainly management of the underlying chronic liver disease, then prevention of viral hepatitis, especially through hepatitis B virus universal vaccination, then health policies, implement measures to induce healthy lifestyle, to reduce the risk of obesity and alcohol dependence, and measures to prevent transmission of viral hepatitis. Then with regards to prevention of progression of the chronic disease, of course, treatment of the underlying disease. And there has been a lot of data showing coffee consumption to reduce the risk of hepatocellular carcinoma in chronic liver disease. So this should be actively encouraged in patients with chronic liver disease. Then take-home messages. Hepatocellular carcinoma is an important cause of cancer as well as cancer mortality worldwide, occurs commonly in the background of chronic liver disease. A good surveillance program is mandatory for early detection in the at-risk population. A multidisciplinary approach is essential for individualized decision making. So like I mentioned earlier in my talk, BCLC is just the guidance. Each management strategy for each hepatocellular carcinoma should be discussed at an MDT, and it should be an individualized approach. Appropriate therapy should be offered to the appropriate patient according to best available resources. Thank you. So again, I would like to thank Ceylon College of Physicians and Sri Lanka Society of Gastroenterology for giving me this opportunity. Thank you.
Thank you. Sorry, I had a connection issue. Thank you very much for the talk. There is one question, if you could kindly take. It's what are the recommended drugs and targets of in patients with ascites due to clinically significant portal hypertension, spironolactone alone or combination with loop diuretics? If you could kindly spend a minute answering that, I'll be most grateful. Thank you.
Yes, sure. So that was on my topic, drugs and targets of management. So spironolactone is recommended as first-line therapy in a patient who is having the first episode of ascites. But in the presence of recurrent ascites, it is recommended to combine it with furosemide, which will actually reduce the risk of complications. And the goal of use of diuretics is in a patient who has edema, the weight loss should not exceed 1 kilogram of weight loss, otherwise daily, otherwise 6.5 kilograms daily. And the goal of diuretics is to use the minimum possible dose for the minimum possible time. And once you start diuretics, you reassess the patient, and if the patient's ascites or the edema is reducing, your goal is to reduce the dose of diuretics and maintain the patient on the minimum possible dose of diuretics to maintain the patient in a euvolemic state. Did I answer the question, or should I elaborate more?
Thank you very much. I mean, thank you for using your expertise to answer a question outside of your lecture also. But since anyway, you're dealing with a malignant, a complication of that as well, because, rising in a background. So I'm grateful that you answered. Thank you very much, Achini. And then we'll try to flash up the state of appreciation but you will certainly get it in electronic or printed form in the near future. This is your certificate. Thank you very much. I'm most grateful as the president of the CCP for you to spend your time and join this forum. So thank you very much, everybody. Thanks a lot for joining. And then let's meet next month with a specialty update, but we'll have other programs from the CCP during the coming few weeks as well. Have a pleasant afternoon, everybody. Thank you so much.